The next condition is carpal tunnel syndrome, which is a very, very common condition. Carpal tunnel syndrome is entrapment of the median nerve in the carpal tunnel. The carpal tunnel is an area just on the volar aspect of the wrist, which has the floor of the carpal bones and the roof of the flexor retinaculum. The four corners of the carpal tunnel are the scaphoid tubercle, just here, and the pisiform, just here. Both of these are on the distal wrist crease, which if it's difficult to see on yourself, you can flex your wrist and it's the deepest crease that's distal at that point. The distal ulnar aspect of the carpal tunnel is the hook of hamate, which is difficult to feel, but on yourself it's often an uncomfortable area to press just over the hypothenar eminence. And the tubercle of the trapezium, which again is around 1.5 centimeters distal to the scaphoid tubercle. This then tells you that this is the area of the carpal tunnel, and when you're looking for scars or performing surgery, it gives you a good idea of the surface anatomy. The contents of the carpal tunnel are your 8 flexor tendons of your fingers, so the FDS, flexor digitorum superficialis, and flexor digitorum profundus to 4 fingers. Then your flexor pollicis longus to the thumb and the median nerve. So there's 9 contents to that. And the cause of it is either from the nerve being compressed due to the area getting tightened, such as osteophytes and the channel getting smaller, some hypersensitivity of the nerve, such as in diabetic patients, or with an increased volume within the carpal tunnel, such as flexor synovitis in rheumatoid arthritis, or ganglia or lumps or bumps within the carpal tunnel. Patients will complain of irritation of the median nerve, and that can be pain in the distribution of the hand and the median nerve, which is the thumb, the index, middle and half of the ring finger. The pain can also radiate all the way up to the elbow, and sometimes that is the only symptom they get, which is pain which is radiating up to the elbow. It's not classical, but it can be carpal tunnel syndrome just from that. They have motor and sensory components to the median nerve. The motor component goes to mainly the thenar eminence. Within the thenar eminence, just on the palmar aspect here, is the APB, abductor pollicis brevis. Just deep to that is opponens pollicis, and then slightly more palmar or ulnar is the flexor pollicis brevis. The sensation, as suggested already, is the digital nerves to the thumb, index, middle, and the radial digital nerve to the ring. But there is slight overlap, so sometimes patients have quite a confused history because there can be anatomical variations or overlap between some of the sensory nerves. One thing to note is that the median nerve gives a branch off around 5 centimeters proximal to the wrist, which is the palmocutaneous branch, which sits between palmaris longus and flexor carpi radialis and supplies the small area of the palm here. And therefore, in marked carpal tunnel syndrome, you should still have fairly normal sensation here because the nerve goes superficial to the carpal tunnel. When we start on look, we're looking at the aspects that may change when you have severe carpal tunnel syndrome. First of all, the thenar muscle, to see if there's any thenar wasting. There isn't always thenar wasting in patients with severe carpal tunnel syndrome because there is often some overlap between the supply of the flexor pollicis brevis and opponens from the ulnar nerve. The APB, abductor pollicis brevis, is the muscle that's almost universally from the median nerve, which is why we test it later on in the motor. The scar, as suggested before, is over the carpal tunnel, so therefore the surface anatomy is important if you're looking for those, and it's often in this fairly central in the wrist, in line with the third web space. And often, if someone needs to cross the wrist to get a more extensive approach, they kick it slightly to the ulnar side. As to the radial side, that you're at risk of damaging that palmocutaneous branch. The other aspect to look for in an inspection is any associated first MCJ arthritis or shouldering at the base of the first metacarpal, as this can be associated with carpal tunnel syndrome. The muscles supplied by the median nerve within the hand are the thenar muscles and the radial 2 lumbricals. The thenar muscles are the APB, abductor pollicis brevis, which is more palmar, the flexor pollicis brevis, which is more towards the centre of the palm and on the ulnar side of the thenar eminence, and the opponent's pollicis, which is deep, sat on the metacarpal beneath the FPB. It also supplies the two lumbricals, which go to the index finger and the middle finger, and the lumbricals cause flexion at the MCPJs and extension at the PIPJs. If you're having difficulty to remember those, the acronym for these muscles is LOAF. LOAF is L is the radial two lumbricals, O for opponent's pollicis, A for abductor pollicis brevis, and F is flexor pollicis brevis. And then if you can't remember whether it's abductor or adductor, then if you remember it's a loaf of bread, the B is for the abductor. There's not a great deal to feel in carpal tunnel syndrome because a lot of it is subjective symptoms. You can feel for the muscle bulk, so to compare both hands to see if there's a difference, but often actually looking at those and catching the light over the muscle bulk is easiest to tell whether it's weighted or not. You can press over the carpal tunnel, and some people it's very, very tender, some people it doesn't really give them much problems. And then you can assess sensation. So in sensation, which I've already mentioned, which can be altered, is digital nerves to the thumb, index, middle and radial aspect of the ring. And there are numerous ways of assessing sensation. You can use discriminators, which see the difference between 2 pinpoints, therefore for 2-point discrimination, pinprick for sharp, Semmes-Weinstein filaments for fine detail. But for most patients, just a simple 10-10 test is adequate unless you're really assessing the detailed progression of nerve healing. The 10-10 test is having the patient tell you out of 10 how sensitive or normal their feeling is, with 10 being normal and 0 being no feeling at all. So ideally you want their eyes closed for this, and you ask them on a finger that you think is normal or on an area of the skin which you think is normal, such as here, if this is normal and 10 out of 10, could you tell me what the feeling is on the hand as I go through them? So if you close your eyes, what's this?
Normal, 10.
Okay. And then here?
10.
And so you can work across the fingers, and if you get some alterations, you can mark those. And that is fairly accurate in establishing when there's abnormalities and also some general improvement after surgery or over time. You would also want to assess the movements, which we've gone through in the general examination, so the thumb movements, but particularly you want to assess the strength of the muscles. As I've noted, mainly it's the abductor pollicis brevis that is supplied by the median nerve. Although the rest of those muscles in loaf are supplied by the median nerve, there can be significant overlap from the ulnar nerve. So the main test for median nerve or carpal tunnel syndrome is the APB. For this, you'll want to place the patient's thumb in the right place. So check that it's not painful, and then lift their thumb up to the sky. Now it's important where you press and get them to resist, because different muscles will work if you press differently on the thumb. So ideally, and I use this for all strength examinations, I put the limb or the digit where I want it and ask the patient not to let me move it. That's much easier than them to resist you or them to place a digit or a limb somewhere if they just don't move. And then the ideal way to press is from the side and push the thumb down to the palm. You don't want to be pushing at the back here because you're more testing the extensors. It's very much from the side. And if you also, at the same time, you can put your finger over the muscle bulk and you can feel it tensing. And if I ask you now to relax, I can feel this muscle's nice and floppy and tense again. It's fairly solid. So you can actually feel the muscle bulk that you're tensing at that point. So when assessing the muscles, if they're completely normal, that's fine. But if they do have some weakness, you need to be able to grade how weak that muscle is. So the grading system we tend to use is the MRC grade, with 0 to 5, 0 being nothing at all, 1 being a fasciculation or movement within the muscle, 2 being the muscle being able to work with gravity eliminated, 3 the muscle against gravity, 4 the muscle against resistance, and 5 being normal. People do often put pluses and minuses around that, but it's not really that accurate to be able to do that. There's special tests for carpal tunnel syndrome. There's 3 main ones. There is Tinel's, Phelan's test and Durkin's compression test. And in that order, they're the least sensitive. So the least sensitive and specific being Tinel's, then Phelan's, then the most being Durkin's compression test. Tinel's is a tapping on the nerve, and this really shows irritation or denervation of that nerve, and is most commonly used for nerve injuries to follow the progression of a healing nerve. But in carpal tunnel syndrome, we tend to use it directly over the carpal tunnel where the nerve may be injured. And this is, if you support the patient's hand, you need to tap fairly firmly over this area of the carpal tunnel, and you can tap for about 60 seconds or whenever their symptoms start. And you need to ask the patient, can you tell me if you start to get the symptoms you have at night or any tingling or numbness in this distribution? And so if it starts to elicit those symptoms, you can stop, otherwise you need to carry on for 60 seconds. So for that, you're irritating the nerve by hitting it. Phelan's test is putting your hands in a position of maximum flexion, as you would do with the wrist examination, and hold them there for up to 60 seconds, again to see if the patient gets those symptoms coming on. And what you're doing in this examination is reducing the area of the carpal tunnel and therefore pinching the nerve. In Durkin's compression test, you're actually forcefully squashing the nerve, and therefore with the wrist in very slight flexion, you place a thumb over the carpal tunnel and press quite firmly. It can be sore, so you need to warn the patient if there's someone who has soreness in the carpal tunnel, but otherwise, again, you hold this for up to 60 seconds or until their symptoms start. The final special test for examining patients with carpal tunnel syndrome or with nerve problems is to assess what their function is. So you want to look at activities of daily living, such as doing up their buttons, taking a pen and seeing if they can grip it without being clumsy, maybe taking the top off a bottle if they have some medicine bottles, or picking up small objects such as a coin. People with carpal tunnel tend to have problems with this due to the loss of muscle bulk in the thean eminence and therefore the strength, but also the loss of feeling in the tripod pinch, and therefore they find it difficult to figure out how hard they're gripping something.